So I have to apologize in front. I just noticed that this translator here doesn't work. So either I need another one in exchange, or we have actually to address questions afterwards in English. Right. We're just talking now in this symposium about the most severe manifestations of psychiatric illnesses. And that's not only bipolar disorder, but the other speakers will also talk about other disease entities. My specialty, as you know, is bipolar, and what I want to do and start off is talking about comorbidities, especially in bipolar disorder, and what we know and what we don't know about managing these disorders. I mentioned already, those who have been in the previous symposium have seen the slide already. There are several conflicts or potential conflicts of interest because I've been working with quite a lot of companies in the past who are actually in the field of bipolar disorder. But to say it specifically for this talk, none of them actually has any license specifically for bipolar disorder with any comorbidity. So if we consider bipolar disorder and consider other major psychiatric illnesses, we find actually a great overlap of symptoms. And we find also a great overlap as far as the long-term course of the illness is concerned. Bipolar disorder has actually quite frequently comorbid substance abuse disorders going along with it. I will not just go more into detail about substance abuse because the next speaker, Michael Seuker, will give you a very sophisticated and elaborated overview about substance abuse in major psychiatric illnesses. They are quite frequent with eating disorders. Around 10 to 15% of our patients with bipolar disorder, and if we take only the female ones, it's more than 20%, have either bulimia or anorexia. But they are most frequent actually with these two here, with ADHD and with the different anxiety disorders. And this is actually what I want to concentrate on during the next 20 minutes. In 1998, a consortium of bipolar specialists was founded, the Stanley Foundation Bipolar Network Clinic. I'll probably have a chance to exchange for the questions. Thank you. And my place of work, Munich, became part of it actually in 2001. This consortium actually consisted of altogether 7 clinics, 5 of them in the US, 2 in Europe, which was besides Munich, Utrecht in the Netherlands. What we did is actually recruiting bipolar patients in those academic centers. It has quite a bit of a selection bias because it's usually more severe bipolar patients which go to the academic centers, and followed them up in the long term and also did intervention trials in the short term in these patients. We collected a lot of epidemiological data, and this is actually one of the first papers which came out in 2001, and it looked into the one-year incidence of comorbidities in patients in this network. At that time, actually, it was a network consisting of 5 US sites and 1 European site. So the outcome clearly is very much biased toward US patients. And what actually Susan McElroy, as the first author, describes is that, as you see, there's about a 40% one-year incidence of bipolar disorder and any anxiety disorders. This is actually almost the same dimension as substance abuse, alcohol use disorder. If you actually add up alcohol use disorder, marijuana, and cocaine, it becomes actually higher than the anxiety disorders. So all these 3 disorders together probably make up to 70% in the one-year incidence. And, as I mentioned, eating disorders quite frequently, especially in the female patients. Now, what you actually miss on this slide is ADHD. which I was mentioning on a slide before. And this has simply to do with the fact this paper came out in 2001, collected data from 2 years, from 1998 to 2000. At that time, there was virtually nothing known that there is something like ADHD in adult persons. It was just restricted to adolescents and to children, and we actually have only data and we only included adult patients. So basically a false negative. If you would make actually the same selection of data or a collection of data again nowadays, we may actually show up also with quite a reasonable amount of patients with adult ADHD and comorbid bipolar disorder. The other thing is this is just about axis 1 disorders. And we know that also axis 2 disorders, personality disorders, are quite frequent in patients with bipolar disorder, probably more frequent than they are in the general population or in other psychiatric illnesses, especially emotional unstable personality disorder. What is the consequence of comorbidities in bipolar disorder? We actually looked in the same data set what are actually predictors of suicide attempts in our patients. And it's actually a worse cause of illness, more time ill, earlier onset, more severe depression, loss of social and medical support, also some things like income status, marital status, traumatic life events, and clearly all these comorbidities are also predicting a higher risk of suicide attempts and also, finally, suicide in bipolar patients. Axis 2, personality disorders, but also axis 1, especially, again, anxiety disorders, and interestingly, also eating disorders. It does not seem actually that substance use disorder is a predictor for suicide attempts specifically in bipolar disorder, at least not more than it is in general in substance abuse. Clearly, it is a predictor of early death because you have all the health complications with it, but not specifically for suicide. However, anxiety disorder is. So let's talk about anxiety disorder and bipolar disorder. Now, one thing to mention as the first thing is that anxiety and anxiety symptoms are definitely not specific to bipolar disorder. They also occur in other major psychiatric illnesses, and they clearly occur in major depressive disorder. Also in bipolar disorder, we find most or highest scores of anxiety clearly during depression. But saying so, there's often also a fair amount of anxiety symptoms in acutely manic patients and clearly in mixed patients. If we compare anxiety disorders between unipolar and bipolar patients, the unipolar one being the yellow ones, the bipolar the blue ones, there is no big difference for generalized anxiety disorder, panic, and social phobia. Interestingly, obsessive-compulsive disorder seems to be more specific for bipolar than for unipolar mood disorders. Now, what's the prevalence and what's the impact of anxiety disorders in other studies? And it really depends what is the population you look into. Mary Kangers, in her large US sample, actually describes a 90% lifetime prevalence of anxiety disorders in bipolar patients. So basically almost everyone with bipolar disorder had at some stage in his life also fulfilled criteria for any anxiety disorder. We saw generally also in other data that comorbidity and more severe causes of bipolar seems to be more frequent in the US than in any other country, especially if you compare it to Europe. So if you look into a worldwide sample, not just a US sample, it comes down to 45%, which is more in line what we also saw in our own study in the United Kingdom. How is it distributed? Emotional social phobia and GAD and PTSD, panic disorder, they are almost equally. Less frequently, actually, in this sample now, OCD and agoraphobia. What is the result and what's the consequence of comorbid anxiety disorder? And we got good data on this. It's lower functionality, lower quality of life, and also other indicators of a more severe course of bipolar disorder, like younger age at onset and more suicide attempts, and unfortunately also completed suicides. If we look into the absolute and relative risk of bipolar disorder, of anxiety and bipolar disorder, it's actually 3 times higher for any anxiety disorder than in the general population. If we ask as a next question, is there a difference between bipolar 1 and bipolar 2? Well, the data we have suggests that there is no difference. Anxiety disorders are as frequent in bipolar 1 as they are in bipolar 2. These are data from the STEP-BD study, which was run in US centers, academic centers, and from the ABC study, a study which we conducted in Newcastle with patients from the north of England. The ABC study was actually only in bipolar 2 patients, whereas the STEP-BD looked both in bipolar 1 and bipolar 2. What you see on the first glance is that actually lifetime prevalence here for any anxiety or disorder in STEP-BD is not 90% as it was described by Mary Kengers, but now comes down to 50%. And this has to do with the 90% of Mary Kengers were just saying, patient, yes, I know anxiety, I have anxiety symptoms, whereas here in the STEP-BD it was a systematic screening for DSM-4 criteria of anxiety disorder. So a more narrow, clearly definition, and that brings it down to 50% with no difference between bipolar 1 and bipolar 2. Now this is much more in line with what we see in Europe, in the north of England at least, which is still part of Europe, also it just wants to drift away. It's also about 50% in bipolar 2 patients who have comorbid lifetime prevalence of anxiety disorder. If you look into the subspecialties, more or less, in the different kinds of anxiety disorder, for most there's actually not a big difference. Where we find a little difference actually between what we see in the bipolar 2s here in the US and in north of England is actually more agoraphobia without panic disorder in England, and on the other hand, less generalized anxiety disorder in the north of England compared to the US. But otherwise, they are pretty similar, and it seems that these are probably the most reliable data because they actually use standardized diagnostic procedures. If you look a bit closer into our patients in Newcastle, what are actually the anxiety disorders, which are listed here? I think what is important, one thing is it's more females having bipolar 2 patients, female patients having comorbid anxiety disorder than males, and actually that there's a fair amount of patients who have either 2 or 3 or 1, even 4 different anxiety disorders as a lifetime prevalence. So it's not just only one, like generalized anxiety. What we found quite often was generalized anxiety plus either panic disorder or OCD. Now let's go to treatment. How should we treat them? And again, I want to start with what the British guidelines suggest. What does the guidelines, NICE guidelines, actually say in the latest edition of 2014? Offer people with bipolar disorder and coexisting disorders such as personality disorder, attention deficit disorder, hyperactivity disorder, anxiety disorders, or substance misuse treatment in line with the relevant NICE clinical guideline. There are 2 problems with that. One is that actually bipolarity was, in most anxiety studies, an exclusion criterion. So we know about anxiety, but we don't know about anxiety with bipolar disorder. And if you look into the recommendations for anxiety disorders, first-line treatment are usually antidepressants. And in bipolar patients, clearly, we might face the problem that some antidepressants, at least, if not combined with anti-manic drugs at the same time, can cause mood switches. So this is not very helpful. What do the BAP guidelines from 2009 suggest? as options for long-term treatment, you basically should go with the anti-bipolar medication, but you might add for a short-term period benzodiazepines or antipsychotic if necessary when acute stress is imminent or present or anxiety becomes prominent, actually with a low grade of recommendation, D. So basically meaning that there is really no study looking into it, it's more or less consensus. This probably solves the problem what we do in acute panic attacks, but does not solve the problem what we should do with comorbid anxiety in the long run. What do we know from randomized controlled studies? As I already mentioned, no randomized controlled trials looked specifically into bipolar patients with comorbid anxiety and what impact treatment has on the anxiety symptoms. There are, for atypical antipsychotics, some post hoc data suggesting some efficacy of olanzapine and quetiapine. But it seems to be not a class effect, so not all atypical antipsychotics work on anxiety. For example, ziprasidone did not when it was tested for anxiety symptoms in bipolar depression. Otherwise, we have some data, controlled data, but actually small studies also for valproate looking into patients with bipolar disorder and anxiety symptoms, not necessarily meeting full criteria of an anxiety disorder according to DSM-4, but having pronounced symptoms of anxiety. These are actually two studies which illustrate what I just said before. These are studies of quetiapine compared to placebo, 300 and 600 milligrams. It almost looks identical if you compare this slide, which actually looks for the Hamilton anxiety scores in these patients, looks identical to what you would see if it were not the Hamilton anxiety score, but the MADRS score, so the decline of depressive symptoms. So along with the reduction of depressive symptoms, we have also a significant reduction of any anxiety symptoms which are present. And clearly, we have to keep in mind there's also quite a big overlap between these scales. So we probably measure the same thing and not really truly anxiety. This is actually one of the studies with valproate, the small studies. In this case, it's actually, again, the Hamilton rating scale for anxiety. This is valproate, this is placebo. And again, it was patients with acute bipolar depression. And parallel to the reduction of depressive symptoms, we have a reduction of the anxiety symptoms. Again, pseudo-specificity of scales is definitely a problem. We cannot be sure whether we truly measure anxiety in those patients who at the same time have an acute bipolar depressed episode. Now, what about psychotherapy, which would be a preferred treatment besides SSRIs for anxiety by its own? There are altogether 22 psychotherapy studies testing a reduction of anxiety in bipolar patients. 7 of them unspecified anxiety, 7 specific anxiety disorders like OCD or others. 8 had actually bipolar depression as a sole outcome focus, not looking into the reduction of anxiety symptoms. They were all done in patients with euthymia, which at the same time means that there was obviously generally low scores, both for depression, mania, but probably also for anxiety. Mostly they used CBT in 12 of these studies and some other techniques in a minority. If you look into the studies, what you can conclude, it's all in small numbers, unclear control conditions, and the evidence in general is quite weak. There might be actually a minor and slight effect of CBT anxiety management techniques. Now I want to switch gears and go to ADHD. Now, what about ADHD and bipolar disorder? One thing is that we have, if you look into the brain, similar areas and regions of the brain who seem to be involved both in bipolar disorder and ADHD, measured as changes in volume in the specific areas. There are several areas where we see similar changes of volume, both in bipolar disorder and ADHD. But there are also some areas where we see opposite changes, where actually this area basal ganglia seems to shrink in ADHD, whereas they seem to increase in volume in bipolar disorder, and the same with the corpus callosum. So it's similar, but it's not fully overlapping. Some features, like the regulation of attention, top-down regulation from the prefrontal cortex and bottom-up regulation, seem to have actually similar mechanisms in bipolar disorder, similar disturbances in bipolar, like ADHD. Now, the other evidence that there might be a close relationship is actually genetic aggregation in bipolar and ADHD families. These are data from the Swedish registry, and it looks actually in 54,000 patients with bipolar disorder, 3.8% of them with comorbid ADHD. In the general population, the estimate in the Swedish registry was 0.2 for ADHD. So as you see, there's already quite a 20-fold higher chance that you have ADHD if you got bipolar disorder. And there must be obviously a genetic background, because the closer you are related genetically, full siblings, maternal half, paternal half, and then adopted non-biological, the more is actually the likelihood that as a patient with bipolar disorder, you actually have also ADHD. What about the other way around? If you look into ADHD patients in the Swedish registry, 4.9% with comorbid bipolar disorder compared to 0.2 again in the general population. And if you look into these patients, you find actually, compare actually this to schizophrenia, you find both for bipolar and for schizophrenia in full siblings an increased risk that you actually also have ADHD, which you don't actually find if you are not as closely related as with full siblings. So a lesser degree with parents for having actually ADHD and bipolar, and with other maternal half-siblings and paternal half-siblings. So there seems to be also a genetic relation between these. ADHD clearly is the most frequent comorbidity in juvenile bipolar disorder. If you actually look for different comorbid disorders, conduct disorder, oppositional disorder, anxiety, tics, psychosis, and so on, substance abuse, you actually have quite frequently ADHD with a child onset, and also quite frequently with adolescent onset in patients with bipolar disorder, young patients with bipolar disorder. But also if you look into adult populations, which is actually studied in these studies, which you see here, comorbid ADHD is quite frequent. If you look at just here in this area, ranges from 9.5 to about 30% in the different studies. If you compare symptom severity in patients having ADHD and bipolar disorder compared to patients only having bipolar disorder, basically all symptom domains you can think about, attentional symptoms, same as actually behavioral symptoms, are more severe or even on a significant level in patients having this comorbidity. What is the long-term impact of having ADHD comorbid with bipolar disorder? It's actually earlier age of onset of the illness of bipolar disorder, more depressive episodes, more hypomanic or manic episodes, most worrying, more suicide attempts, and if you got already ADHD as a comorbid disorder, it also increases your chance to have another comorbidity, namely anxiety, substance abuse, or access to disorders like antisocial personality. And finally, and I think quite important for the treating clinicians, you got mostly poorer response to any medication, mood stabilizers, especially we don't know yet about, or not clearly about, atypical antipsychotics and poor psychosocial functioning. So what do we know about pharmacotherapy and what we don't know if you look into comorbid bipolar disorder and ADHD? Some earlier reports, basically from the late 90s and early 2000, described that adolescents with bipolar disorder and ADHD have an inferior response to lithium and valproate in acute mania compared to those not having this comorbidity. The ADHD symptoms, not the bipolar symptoms, appear unresponsive to mood stabilizers in this combination, whereas they actually do respond if you give ADHD-specific medication, like amphetamine derivatives, for example. And they actually do persist, these ADHD symptoms, in bipolar patients even during euphymia, so they're not coupled to acute episodes. We have few studies only, and these are listed on the right-hand side of the slide, looking specifically for ADHD symptoms in bipolar disorder, but they don't really generate any evidence for optimal treatment. Many medications have been tested in these studies, which are listed down here: lithium valproate, carbamazepine, risperidone plus lithium, risperidone plus valproate. But there's obviously no big difference in all these medications, and basically, actually none of them actually reaches statistically significance. They all touch the line of equality to placebo. So what can we actually suggest to patients? First, what can we suggest how to treat the ADHD symptoms in bipolar patients? There are actually some studies looking also into outcomes in ADHD when using, as you see here on this slide, ADHD-specific medication. So methylphenidate seems also to work in patients with ADHD plus bipolar disorder for the ADHD symptoms. A lower level of evidence have other mixed amphetamine salts. Again, a lower level of evidence, bupropion and tamoxifen, and some case reports also exist about these treatments. Highest level of evidence in this Canadian guidelines was actually for 2 or more placebo-controlled trials or meta-analysis. Level 2 for 1 randomized controlled study with placebo arm. Level 3 for prospective open-label studies. So methylphenidate, first message, works. However, clearly, we might put patients on risk for switching. So what are alternatives? And one interesting alternative which came up was actually bupropion as an antidepressant, and also with dopamine-enhancing activity. And the idea was it might not only work against the at least depressive bipolar symptoms, but might also actually improve attention. And this open study, which was conducted in 36 patients, were again low-grade evidence in patients actually with bipolar disorder and ADHD for 6 weeks, suggests some benefit of bupropion monotherapy. So for ADHD symptoms, you have a reduction with bupropion. For the Young Mania Rating Scale, you got a reduction with bupropion, interestingly, with an antidepressant. Same with Hamilton, actually, depression scale, and also with the Hamilton Anxiety Scale. But again, open data. So what is actually then the strength of evidence now for treatment in adults? The first one was actually, forgot to mention it, was actually for adolescents. Level 1, evidence none. Interestingly, level 2, atomoxetine, and again, level 3, bupropion, but also other antidepressants. What are the recommendations derived from this? In adult patients with bipolar disorder, this is compared here to patients with major depressive episode, first line is actually bupropion, which seems to at least cover most of the symptoms, both of bipolar depression and unintentional symptoms or attentional deficit symptoms in these patients. Second line, third line is then amphetamines and tamoxifen, because clearly they might work, but they might have inherited risk of switching and destabilizing the mood. I come to the summary. So ADHD is frequent in bipolar disorder, not only in adolescents, but also in adults. Genetic, neurobiological, morphological findings suggest that bipolar disorder plus ADHD might constitute a distinct subtype of bipolar disorder with overlapping genetics and pathophysiology. Clearly, ADHD in bipolar patients has a quite pronounced negative impact on short and long-term outcome, and unfortunately, the evidence for optimal treatment remains scarce. Either it's not very effective, or it might put patients on risk of switching into the opposite pole of bipolar disorder. Well, thank you for your attention.